presentation. He did a great job introducing himself, though.
My patients know all about him before we even start the visit.
She tells them that I'm interning, finishing up last trimester.
When you're graduating.
I'm engaged to her niece. I'll be here till October. I was like, this is our intern. Is it cool to chat with? Like, okay. That's it.
Well, good luck now. Now I'm going to be like, Clayton was born at 1 a.m.
He has 10 fingers and 10 toes.
Oh, sorry, we didn't get to treat you because that was Clayton. Welcome back. Week in review, I think number 16. If my memory serves me correct. We have Monica, Daniel, Sloan, Clayton, Pitas. Giant package.
Peta. What movie is that? What is that?
Hunger Games.
Hunger Games. Hungry Games?
For you, it usually be. Yeah, super funny. Pitas.
And let's go.
Yeah. We have to go because Sloan's got a case to present today. Monica is, so we've decided that with the four of us, one will be a moderator, largely based on the amount of time Sloan takes. No. So somebody can always be maybe breaking up the cases a bit. So it's not just monologue questions and that today, that is Monica. So I'm leading off here. So let's roll. 45-year-old female comes in the clinic with right arm overhead. Like our office faces the parking lot, and Monica goes, "Is this your patient?" She's in, if you're looking at the camera, she's like this walking in. She's moaning in pain, accompanied by her husband. Notes that her husband was not moaning. He was just with her. So should have been written different. Notes that she was in a motorcycle accident back in November, resulting in 10 fractured ribs on the right, fractured scapula, and severe neck pain. So she went down, and then the girl riding next to her ran over. They're still friends, and they both still ride motorcycles. No treatment after all that besides rest. So you got to think scapula and rib fractures. So not a whole lot they do, right? Should have had PT, didn't. Had a bunch of CT scans, all that, brain imaging, no crack in the helmet. So basically just rest. She's a flight medic, now an international flight medic. So she's usually gone for 2 to 3 weeks at a time. She was a traditionally a respiratory therapist. So she is kind of from the medical field. 3 weeks prior to the visit in our office, she had the gradual onset of neck pain that started to radiate into the inside of right shoulder blade and down right arm, with numbness tingling down right arm and entire right hand. And she just said it's been escalating a little bit every day with no sudden onset. It wasn't like she did something. She just woke up one day and it's just little by little growing worse and worse. It's worse with all movements except cervical flexion. And obviously, again, she's with an arm over her head. We'll talk about kind of other postural findings later. She saw an orthopedist 2 weeks prior to our visit. She had both a shoulder arthrogram and a cervical MRI. The findings on the cervical MRI were many, right? And then do we pay a lot of homage to that until we done an exam? Not a ton until we done the exam. Significant findings, C3, C4, C5, C6, central canal stenosis, 3 levels. There were disc herniations at C5, C3, retrolisthesis at C5, C6. There were findings at all levels. Granted, this just showed up 3 weeks ago with nothing majorly changing. So then it's like, I'm not saying those aren't important findings at all, but I also don't know how important they are. She also had the shoulder MRI, which only returned with edema at the end of her right clavicle. She's been using NSAIDs as needed with little relief. She also, when she went and saw the ortho, they started her on 1 5-day dose pack, and now she was starting her second 5-day dose pack the first day she had seen me, which she didn't say it changed a lot with the first one. So that was kind of the history. Anything on that I feel like I missed or you're wondering about yet?
It's only on the right side?
Yep.
Nothing on the left?
Mm-hmm.
Okay.
So beyond the presentation of Bacotti sign, she's stuck in severe protraction, right? And just asking hey, you're here. Yeah. As soon as she goes back, just immediate radiation down her entire right arm. So she's again, if you're watching the video, massive protraction, just kind of hanging out. And she keeps going through this, and put it up and just bring it down, shake it out, and bring it up. So, I did not do a top tier. Right. No, you're not today. I didn't do a gait analysis. Sorry. We're not going super functional on this one. We're trying to see what's going on, how we can decrease pain so we can look at more stuff later. Cervical range of motion. So cervical rotation bilateral, she actually was more restricted to the left, but there was pain bilateral with radiation in the arm bilateral, right? So she's more limited to the left. She can go further to the right, and both cause the exact same amount of pain though. Retraction, like I said, reproduce pain at CT junction and dorsal scapular innervation. And left rotation did not create radicular symptoms, did create neck pain. And then, like I said earlier, flexion is the only thing that kind of doesn't bug anything. Just hanging there doesn't also alleviate any symptoms, right? Just being in flexion doesn't like take pain away. Neuro, so +1 on DTRs on the right, +2 on the left, negative Hoffman's and Babinski, all cranial nerves intact. 4 out of 5 on all myotomes. Also, we'll get into kind of more of the functional stuff around like she has scapular fracture. We think maybe the edema in the end of the clavicle has a lot of functional components to a primary impingement, and her shoulder, even though remember the MRI was pretty much clear, but then like everything around it. So I'm not taking that as like any neuro deficit. That could all just be like there's a bunch of pain and it's not awesome. No symptoms of coughing or sneezing. So big thing here around her shoulder blade, extremely low tone, right? Not quite atrophy yet, but like she feels like everything's super tight, right? Extremely low tone. Like there's a mild trigger point and upper trap that probably everybody in the world has almost. Besides that, like super low tone, a little bit of lat trigger point. Yeah, Daniel just checked, he doesn't have it though. But her complaint is, it is so tight. She's sitting here doing this and then shake it out, go back to here. All shoulder orthos are normal in the face of how bad her pain is. Does that make sense? So you still kind of got to run through them, but like, I'm not finding anything where I'm like shoulder. So that being said, should check them at a later date when she's a little bit better. Almost all cervical spine orthos are positive. Jackson's, maximal foraminal compression, Sperling, shoulder depression. This is what I told Clayton. Had I not had an MRI based on the findings, I would have thought a cold fracture, right? Like, I mean, minor percussion, every direction. Her going from flexion to upright immediately brings on pain. So it's almost like a, whether it's like core compression or instability. Now she doesn't have cervical instability sign, right? She can get up and down off the table. She's not holding her head. She doesn't have rust sign. So that kind of takes that out. But again, everything you do is just lighten her up, and she does not like being upright. She would rather be out here and kind of locked in with cervical extensors. TOS testing is all negative because one of the things that she actually said on the follow-up visit, I'll skip ahead on, was when she would do some of our drills, her whole hand would go numb, but it would also feel extremely cold. But then it would return after the drills. So I went ahead on second visit, checked TOS, completely normal, right? All your typical like 3 or 4 tests there. And all neurodynamics on the right, bilateral, are normal, but she's also extremely mobile. So there's a lot of stuff that points like, brachial plexopathy, things like that. But she's hypermobile, has no shoulder pathology, has edema at the end of her clavicle. She could easily like fool us a little bit by being just like more flexible and not showing that, but nothing's like overtly positive. So that's where now I'm starting to think less actual like cervical radicular stuff. And either we have like something around the scapula, like a functional thing that's kind of driving pain. Also the way it's onset, and she lifts patients, right? So, and she kept working. So she's been lifting patients, riding in a helicopter, doing all this stuff. So it's not like her job's not a little bit laborious.
Can't imagine doing that job with her presentation.
I asked her, you've been working? She goes, oh yeah.
I mean,
she kept working after she saw the ortho. She had only stopped working a week prior because they sent her home at work.
Yeah. I can't imagine laying on the beach in her condition, let alone flying in a helicopter, helping patients. Yeah.
So 4-point rocker, right? Typically like a functional test for scapular stability. When she gets in that, she would keep her right elbow bent. You could see massive like flaring of her right shoulder blade around kind of the superior angle of her shoulder blade. Almost like hypertrophy, but also like hyperostosis, right? And then that's what I asked her on the second visit. Is that where you had a fracture? And she goes, yeah, it fractured from the superior angle down across the infrascapular fossa. So like that's where it fractured. And now off of that, where a bunch of stuff attaches, right? Who knows what's going on, but flaring, low tone, kind of as she goes forward, obviously she's in protraction and just going forward like a little bit and back, like immediately just down her arm. To the point where we did it and we watched what happened. I was like, okay, we're done.
But tension tests were negative.
Right. Completely negative. Like literally just like everywhere.
Even with cervical head movement?
Mm-hmm.
Does that make sense?
Does later.
Okay. I'm just trying to wrap my head around that. How is it negative?
Right. So that's where, okay, so what are we also seeing? We're seeing whole arm presentation of all the radicular symptoms, right? We're saying wrapped around entire arm, pinging with all movements, no directional preference, right? Shoulder movement doesn't create any of that. Okay. When you load her shoulder, it immediately brings on symptoms. So where's that direct?
Am I crazy to just think vascular in her neck I know that is way out there, but you said, it's entire arm, not just
right,
specific dermatomes.
Vascular, we just rule it out.
Ah, okay. Sorry.
No. So when you load her, 4-point rocker, right? Second visit, we did 5-month sideline stuff, but when you load her, that's the worst, right? So what's that direct you guys, or what are you thinking? I obviously know, so I'm not playing the guessing game, but so she has to incorporate the things that would stabilize her scapula. So it's notorious in scapular fractures that like the musculature around the scapula turns into like a static fixator, right? Like now you won't allow it to move because you can't go in there and brace, cast, or whatever, paper thin muscle across the infrascapular fossa. So you have a tendency to go into like this tonic phase with like subscapularis, serratus anterior. She goes to push, she's immediately just lit up, right? So you had a patient with like some lat stuff. So for her, you knew immediately based off exam, like we're not going to be pushing her into like typical McKinsey stuff. So I'm trying to look for just like palliative movement here. So my functional audit was scapular dynamic stability, right? Can I start to just get movement to occur while she's loaded, right? She can literally do this. She's walking in like this. So that's why I was like, you will fake us out because it looks like it's this not a shoulder thing because you're like doing all this, but it is a shoulder thing. So where are all her symptoms? Dorsal scapular nerve, right? Down her whole arm. So when we do cervical flexions, almost immediately she's like, hey, bilateral rotation's quite a bit better, right? And that's like, I think 15 reps. We had her do 2 sets, 15, quite a bit better. And that's why I was like, well, at least take that. We did a bunch of dry needling around, all over periscapular region, upper trap on the right, kind of down through the lat, more for input, right? A lot of afferent input because we're seeing low tone, decreased DTRs, really no. So again, I think we said this on the podcast before, when every orthopedic test is positive, it makes me think less like specific pathology and more like functional, like adaptation. And you're like, pain is now like your elicited response. It's your body's trying to get, some sort of response to. So dry needling, we taped all around periscapular region again for input. Cervical flexions with overpressure was one of the exercises we sent home. 5-month sidelining as much as she could bear, right? So when she gets in that position, she gets like a toothache in her shoulder, but she got no referral, right? She would be like, man, this is just like, work perfect. Cool. And then I didn't adjust a damn thing. Not a chance. Even though we had, would be, afferent via, T-spine adjusting be good? Sure. Could also be the worst thing in the world for just based on the input, right? Not thinking there's any risk there necessarily. So like I said, homework, cervical spine flexions, overpressure, dead bugs with her head elevated. And my coaching cue was, because she's still here, it's like just start with a towel and try to work yourself down to neutral. So at least we can start getting you back in her retracted position. She got all the way down by the second visit to flat on the floor, which I didn't think she would get to. All right. So she was doing flexions, immediately going to dead bug, flat on the floor, hanging out for some breaths. And then I had her do 4x4 rocking. What she said was that when she would do the 4x4 rocking, that's when the hand got cold, stuff like that. So that's where we started playing around on second visit. She comes in. Just overall demeanor looks a lot better, right? She doesn't look as distraught. She's not in protraction. She's pretty neutral at this point. She says that she's better. And then we test DTRs +2 on the right now. So that's already improved. C-spine rotation is better bilateral, still range of motion decrease to the left, but there's no radicular symptoms from returning left or right now. I'm still not going after this because as soon as you send her here, it's immediate whole arm. Now I could have pushed through that, but you'll find out here in a second because I saw her yesterday and then we got a phone call today. we really went after like scapular dynamic stability to try to offload that whole area. But really, I'm thinking like afferent input. So we went through 4x4 rocking, having her really load stuff up. So the funny thing was, even though she would get symptoms, the further she went into flexion 4x4 rocking, really having her push, when she got done, it severely improved symptoms. So she would be able to move around. She could go through lateral flexion, a bit of kind of extension, wouldn't have any of this stuff going on. So off of that, I was like, hey, our big deal with you is we need more of the 5-month sideline, more like pushing, whether it's on the wall or on the floor. So we start engaging this stuff and seeing if just kind of like changing how you're moving around your scapula is going to offload some of this stuff. Cause I'm telling you, like there, in my opinion, I have it written in my diagnosis as brachial plexopathy. The other ones are maybes, but I think she is just operating around there in such a way that is like aggravating everything. And I don't know if there's a specific diagnosis. Now, core compression kind of ruled out. There's no myelopathic like findings. Doesn't mean that there isn't, right? But so here's the follow-up. That was the visit yesterday. We get a call today from her husband and he says, Danielle is having terrible pain. So her pain though is in CT junction, right? So I sent her home with cervical lateral flexions because when she went, I'd like her to go to the right. When she goes to the left, it was fine and it opened up right. So I was like, here's our plan. Work to the left until right's really good, then start trying to do overpressure to the right. And then maybe next time we can start working through retraction extension. But she went in there and we even said this, but again, people go home and they have, minor freakouts when pain increases. She goes home and he's like, she is dying up around her shoulder blade. How's her arm? It's better. I know that sucks. Yeah. Cause this is her main complaint by far. Like she always is saying it's in my shoulder. You had to fracture your shoulder blade. You had no PT. There ain't no way that it doesn't move, right? It stays in this flare position. Her shoulder moves around. That's why her interclavicle's edematous, right? She's just primary impingement. So my goal is like get that thing moving. And then then we have symptoms that persist beyond that, then I'll start exploring more specific stuff. So plan right now is keep going in the face of pain unless radicular symptoms get worse. Yeah.
Was she sleeping okay before coming in?
Not necessarily. She did okay on sidelining. Obviously transitions were hard. She couldn't lay on her back until she was using a cervical pillow was the only way she could lay on her back. So a lot of it comes down to like cervical instability, right? Like she's been like this for probably quite a while, unbeknownst to her. And now she's just like stuck in this like high threshold pattern around all that stuff. So again, there may be 5 visits from now, a way more specific diagnosis or a change in findings, right? Where all of a sudden it's like, oh, it's C5, C6 derivation settle land, and we're seeing stuff like that. I think you kind of got to like clear the mist around all that stuff.
Yeah.
So scapular rocking, what else, or was that the only thing you did to low scap?
Besides 5-month sideline.
And then, yeah, I felt like I heard that second visit, but that didn't happen first visit.
We did go on her side. That's where she was like, this is achy. That's why I didn't send her home with it. Okay. It was really bugging her. So like I kind of picked my poison on like the 4x4 rocking wasn't great, but I have to get your shoulder blade moving. So, and it worked out. I mean, she could have shown up and been like terrible. Right. Any questions, thoughts?
Scalenes felt fine the whole time.
So like I said, if you go into her neck, like tone wise, even though she's here, like low tone overall. Yeah. And like the only place I would say I was dry needling like trigger point would be lat and upper trap. But if you think if she's not like accessing like serratus and like subscap, like that would make sense because that's how she's like fixating her shoulder blade to her rib cage and then moving her shoulder around. And if it was me, this is what I told her husband, I would only be getting up to like here just based on like my shoulder range of motion, right? She has fantastic mobility, so it looks normal. Shoulder blade and her humerus is just going like this. For those people listening, we're saying her shoulder blade's fixated and her humerus is able to still get 180 degrees of flexion. So yeah, interesting. And I'll try to do an update on this one because it could change. I'm just being honest. Like she could come back in worse because it's like we're using directions, not classical McKinsey, right? We're just kind of following what works instead of saying what we think we should do. And then, we may get to a point because she also has that retro. Right. So classically a retro going this direction and there shows a central disc protrusion. That could be, you'd be going in flexion. It's like, I don't know how far we're going to get with that stuff, but she looked so much better posture-wise the second visit. So we'll see.
Nice.
Yeah. Sloan's still writing vigorously.
I did take some notes.
Oh, about this one?
Yeah.
I thought you were writing your case out.
Well, yeah, that too. But what kind of rocked me in the very beginning is thankfully she had like the imaging coming in. Let's say that she didn't and she presented like that.
She would have been out of the office for
Okay.
2 reasons. One, she's an insurance patient. If you're in a car accident or some major accident involving somebody else, you have to have imaging to have treatment if insurance is ever going to cover it. So that's just a technicality.
For like a personal injury.
Right. Second, that presentation out of the office.
Yeah.
I mean, absolutely. And that's advanced imaging, in my opinion. It's not x-ray.
Yeah. And I think you and I have had the conversation before. You know, what really makes you a good clinician is knowing when to refer, like when to get them out of here and not hold on to them.
But that's why her case is such a good learning case, because we had the imaging first. So you can do a lot more with that. And you're both having shoulder and neck. You're like, you get to learn almost what the exam may or may not dictate.
Yeah.
That's kind of
cool. You've got a little insurance policy there. Yeah.
Insurance policy, but like, it's rare that like you would also, I mean, an ortho has it before. What do orthos not do though? An awesome exam. They would go off the image.
Not every,
in general.
I'd hate for them to say every chiro doesn't do a good exam.
In general. But that's what was cool. So like, then that kind of changes the thought process sometimes. Like, man, it would be cool to have imaging to learn every once in a while. And I just think like based on the severity or what they've done before, like I've changed, I think like say somebody's come in and they've seen a bunch of people and it doesn't seem that extreme. I think that still warrants imaging. Having seen a bunch of other practitioners, even if you're like, let's say it's plantar fasciitis, right? They've seen 6 different people, right? 2 podiatrists, an ortho, a PT, running coach, right? And they're all working on this thing. Like, I would say go get an image. You know what I mean? And then we can at least like kind of have an educational moment with them, but then also like clear some stuff that may not be picked up. I think like I changed on that of like, hey, instead of just going fast, like go get the image. So we're the person that's not just continuing what everybody else has been doing.
Yep.
Any other questions?
Yeah, that was one that I was kind of hoping we would get to talk about. Like, I think after you saw, but we were both busy.
Yeah.
Just to kind of, because as she walked in, Monica even like looked through the window and just like, is that rust sign? Like
at first I was like, rust? She was supporting her head.
Mm-hmm.
She leaned on the truck, like when she got out, like, and then she was moaning. I mean, she's definitely in pain, but she's also super tough. Yeah. Which could be to her disadvantage in this case, that she just like rock and rolled for how many months? I mean, almost 7 months since it happened.
Yeah, she was definitely in pain. But when I saw her walk in the other day, it was
just demeanor, it was like
she was smiling. Her hand wasn't over her head.
Yeah.
I was like, oh,
It's great to see you like this.
Yeah. And that's what, I mean, getting that call today is kind of like, I'll just be honest, my first reaction was like, oh, just keep doing your exercises. But then like I had to make, like I initially told Bridge, I go, just have her keep going. And I was like, wait a minute, let me find out if it's like central or if it's peripheral. Cause then I even told Bridge, I go, if it's down her arm, just have her go back to flexions. And I was like, well, I can be smarter than that. Right. I can say, hey, central. Oh, actually keep going. Maybe push that other way now. Like that seems crazy and it may be worse for an hour or 2, but it may get better.
Now, do you have that conversation with your patients in the office
100%.
about centralizing and peripheralizing?
In her case, we didn't talk about centralization. What I was basically saying is the lack of movement around, like you're compressing the snot out of CT junction based on how you're kind of stabilizing your scapula. So our first goal is get your scapula moving. Then we got to get motion however we can in the CT junction. The ways that you don't want to move may not be based on pathology, right? Like it may not be like, oh, you're hitting a disc herniation. Like you just may not want to move in those areas. We don't want to necessarily like push it, but we want to like test. So like, okay, flexion's good, great. Hey, left's good. Oh, right's good. We're still keep hitting the end here. We may have to like, I mean, you know this, we can go back through that, right? And like figure out like, hey, we do have to go back to flexion and then do this immediately. Mm-hmm. So it's just like, that's the big process with her is like, it's not a classic McKinsey case because of so many different things going on. But we can use it to our advantage. But I think I'm going to get away from McKinsey and go hardcore DNS because of the stabilization around here really quick.
Mm-hmm.
Yeah.
Well, that's something that Clea and I were briefly talking about is that when is it just general movement is beneficial for that person?
And that's what I hate to say with this case, but like my thought process towards the end of the second visit was, what if I just had her start doing like scapular cars? right?
Mhm.
Because she gets crepitus under that shoulder blade. What if I just had her literally, what if I had her do them loaded, right? Because we're saying like what if I had her do that and push on a rubber band and do scapular cars? Would she come back in like, whew, this is feeling awesome? And then you like snipered it, right? Instead of like flexions, lateral flexion, 5-month sideline. I don't know.
Well, the next time someone walks in with their hand above their head, you can try it that direction.
Yeah.
But that's why this is practice.
Sure.
That's why there's not that one easy protocol for
Mm-hmm.
every patient.
Yeah, I mean, we could have done a lot of different stuff with her for sure. But obviously, we'll see if it's working. I mean, you never know. Like we could literally go 2 more visits and everything just cascades. That's the one thing that I did mention in her history that I really was the most concerning thing was the slow, gradual increase in all the pain. Like the first thing that I thought when I heard that was cord compression. I thought like some sort of intercanal swelling, or something's going like a syrinx or cyst, like you had some sort of impact and you're just now kind of maybe you're contusing your spinal cord where you didn't know something. And that's why I was like, because she was just like, it's getting worse and worse, and she's taking corticosteroids, and it's like, it shouldn't get worse. Then like if you're taking steroids and it was swelling, that doesn't really make sense either.
I sincerely apologize, but back to kind of my thought on vascular. I mean, let's think differential diagnosis. What could potentially be a vascular compromise that could lead to that? Like I'm even thinking
But she doesn't have
cord
any
level,
of the
like
presentation.
any kind of stroking or anything like that. No.
Yeah, but so what would you have in stroke that she didn't have? What would be your first few signs? Upper motor neuron
Yeah.
stuff, which she didn't have. She also had no vascular signs as far as capillary refill, any kind of color change, any swelling.
I guess I'm
pallor.
just stuck on like the entire arm with the temperature change at the
But
distal.
the temperature change is her perception.
Yeah, not
So
your
that might not
perception.
actually be the
Right.
temperature.
Got it.
And that's what lateral spinothalamic tract.
Yeah. Okay.
So that's what, like, I went up to her hand while she was doing her 4x4s, and I was like, and then immediately did capillary refill when she got done.
And it was fine.
Same.
Okay.
And that's what, again, like perception is very different than outcomes, but that's why we tested all TOS, all that stuff, and nothing showed up, which I agree with you. But again, nothing matches, no like decreased DTR, no upper motor, no vascular sign. So yeah, you want to rule all that stuff out.
Like I'm just thinking something that may have not shown up.
And
like
we mentioned
cord compression would.
a cold first rib fracture because brachial plexopathy. Like we mentioned that stuff to her, but I was like, I just don't think that is, because you push in here and she's like, oh God. But think how much stuff's going on with her. I mean, that's where I think you can't get too specific right now. Like imagine if somebody came in and their shoulder blade hasn't moved for 6 months.
Gosh, you can also get like aneurysm of subclavian vein there. It just is so different of a presentation. I'm just thinking off the deep end,
Yeah.
Okay,
I think
so I'm
I
gonna say
would-
this. I was gonna say, when was the accident?
November of last
That's
year.
why I wouldn't be as worried about vasculars, because I'm like, if we would have seen it, it would have been however many months ago. I don't think I'm going to see it today if the accident was in November. I mean, unless something else, like we're talking about what, less than 0.1% maybe.
Yeah.
But also no visual sign, cranial nerves. Like you also can't just, the whole hand thing, I know gets a lot of people. I would say in the last 3 months, I've probably had 10 people with whole hand symptoms that are pure cervical radiculopathy. And you'd be like, well, that's not classic. Well, I also think that you get a lot of not plexopathy, but brachial plexus
interruption.
neurodynamic issues
Absolutely.
based off of the movement aberration. And that's
not
harder to pick up because you're not like, oh, C5, C6.
Yeah, it's not only at C6. Yeah.
And I think that's something that's probably not talked about a lot, but then that gets into is that radiculopathy or radiculitis. And the irritation can be far outside of just like that nerve root level.
Yeah, I'm not suggesting these things saying, oh, you should have ruled everything out. I'm spitballing. I'm thinking, what are the other options that could be out there,
Yeah, and I think I say we because Clayton was in there. I think we did.
Yeah.
Right. I think there wasn't, the only thing that I left off the table, to be honest with you, was TOS stuff, just because the only thing that why I went back on that, which I probably should have checked the first time, is when she came in, she's like, my hand gets cold. And then you check it out and you're like, well, that stuff's negative. Yeah.
Okay. Very cool. Very, very interesting. I'm going
give an
to
update
continue
next
thinking
time.
about that for sure.
Yeah. Who's up?
I got a real quick one, so I won't stay on
Please
it.
take note of that. Daniel says, real quick one. Let's start the time. If everyone's going to get at me about taking so long.
It's 2:45.
Okay, I can finish this in about 2 minutes. Okay, so I had a patient, younger one, who happens to be friends with one of Beau's patients and was referred here. His mom thought that he needed arch support and was worried about a valgus knee loading when he was like standing on second after hitting a double. He has no foot pain. He has no knee pain. He has no pain anywhere in
Like
his
that was on
body.
her own accord. Like she saw his knee.
Yes.
Oh.
And like, well, I think of both parents just kind of seeing collapse, just kind of like standing there, just not just.
Yeah.
Yeah.
Huh.
So this mom has told me about all her art sport knowledge and how she has already
Does
bought him.
I'm curious, does she have any foot issues?
Not that she told me. I didn't
just
ask
wondered
you.
if it was like displacement.
And so she bought him orthotics off Amazon.
Nice.
And he's been wearing those for however many weeks. I just made sure I asked the mom. I was just like, okay, so he has no foot pain. She said no. He's had no knee pain. And she said no. Nothing at all would make her lead. And nothing has changed since wearing these new art sports. Anyways, so I was like, okay. I told the mom, you know, what, maybe 1% of the population maybe actually needs orthotics.
Like
And-
long term. Yeah.
Right, long term. And so quickly, before I even look at him, trying to just like, because the mom was like, is this good that I'm in here, or am I crazy for bringing him in here? I told her she
What
was
was your
crazy.
Here's your straitjacket.
But exam, everything looked good. I mean, of course, it's like if you wanted to point out like scapular loading as far as SFMA goes, but all neuro is good, all SMA is good. I don't know why I can't clear my throat.
Let me clear my throat.
So I was looking for just a cool one to kind of talk about on the podcast, and Clayton got to watch this one too. So I guess Clayton 2 for 2. So while I'm still talking, Sloan may could change hers to make it a 3 for 3.
I think this is a 3 for 3er.
So Clayton said, well, why don't you talk about the one with the balance issues? So again, the only thing the SFMA showed is that he couldn't balance. We broke it out balancing. And again, even when we broke it out, you know, single on the knee, kneeling, nothing changed. Still terrible balance. So then when I go to immediately want to look in his eyes, nothing changes. Because if we know how just balance and all that works anyway, we talk about it all the time in the office, eyes, ears, and then we talk about muscle, bone, tendon, ligaments, everything else. So we look at his eyes, they look really good. And then we start doing some vestibular drills, and you kind of see basically everything vestibular wise, like could not do. So like looking up, like if you wanted to look up some VOR drills for experimenting with patients and kind of seeing how many patients actually are not any good at this, it's a lot of them. So
Which then makes it like, who do you actually do it with? So it's hard, but like this kid didn't have anything else, right?
Right. And so again, like the way I kind of look at it is like, we're still doing an exam. I'm still seeing what changes versus what doesn't. So we do the VOR drill and we retest balance, and balance is phenomenal. And
Direct specific direction, like diagonal.
we did
right,
all of
upright,
them. I mean,
or-
he hit, I would say diagonal and like horizontal.
Okay.
Was the biggest two. Just because like a lot of times if I see two that are close, like we sit in the drill home, I'm like, it wouldn't hurt you to do all three.
And so for people listening that aren't familiar with VOR, it's basically keeping your eyes locked on a fixed target and then moving your head around and seeing like how well you track across that, how well your eyes fixate on the target. But also when somebody isn't great at all directions, right? We think less specificity of like vestibular, actually the VOR, and we think overall like vestibular disturbance. So that's where like possible upper cervical stuff, like how well
Right.
do you move through there and things like that. Yeah.
And so speaking of like upper, which is kind of why we started doing some like deep 3-month stabilization for deep cervicals. So yeah, we did that, and we talk about like short foot loading.
To
Just some, like-
appease the mom, or
Yeah, to appease the mom. And it's just like, you know, you're a 10, 11-year-old kid who couldn't
seems
also
young.
load their hip better
yeah.
and get better. So I think I looked at the mom, and I've only seen the kid one time, and I just said, hey, this could be, I was like, in a perfect world, this is what I'll say a lot of the times. it could just be the eyes, it could just be the ears, or it could be the fact that we're doing all this loading, and it's not a perfect world, so we're going to hit it with everything.
I'm curious, has he had glasses or anything?
No.
Okay.
No glasses, which I kind of attributed to, like, I think because he seems like a good athlete, and his mom said, I mean, again, I don't know if all moms say this, I know my mom would have said it, but like he seems to like play all-stars and do all that kind of stuff. So in my mind, it's like, could this be the missing link to put this kid's athletics even higher?
That's fun. That's
And
fun
so-
to add to it.
And so I always think that, I think that's super cool. Book that Beau gave me that I still have not finished, See to Play.
Yeah.
And you kind of get to see how, one, was he an optometrist, and how much he changes the eyes and how good he felt like he could have been if somebody had looked at all this sooner. And so I feel like I treat every athlete like I wish that I had me when I was younger.
Yeah, somebody to look at everything.
Yeah.
In case. Yeah.
And so, again, I saw him one time. I think his mom was just happy that like we were literally checking everything with his eyes, his ears, all things. And now I get to see his sister as
What was
well.
your suggestion on the orthotics off Amazon?
Oh, I said, you don't need them at all. And then I said, if his foot bothers him at all when he gives them up, then wear them every few days. But like if he didn't have a problem before, then he doesn't need them.
Give them back to Bezos to fly to Mars with.
I was going to say, take those suckers to Kohl's.
Yeah.
Free return.
Yeah.
But and then I wanted to hit
Yeah,
a
keep
real
on.
quick update on my last one. So my hip
which
one.
Yeah.
So what's funny, because I just saw him today, and I saw him for roughly like 2 months, where even though I told him he didn't need to come in, I think he liked it that somebody was helping him load his hip. And so Beau heard this as he's leaving. So this is the first time I hadn't seen him in 2 weeks. Like he works out of town, just some scheduling stuff. And I looked at him and I was just like, hey, how'd you like the 2 weeks? Do you want to do that again? You know, what was his response?
He just goes, no.
Like he wants to do it
Yeah, he just
more.
goes, how'd you like having that 2 week break? He goes, no.
He wants to be here next week.
Yeah. And so it was
He had a
just,
couple times where he would come back to back days just because that was only.
there was
way
only
to
2 days
do
he was
it.
here.
Yeah.
Yeah. And so he was just like, he's like, no, I want to do 2 days. He was just like, because then I know that if I schedule them both and I either make both of them or I'm just going to make one. I was just like, okay.
And there are people that are self-aware enough to realize they're not going to do it.
Mhm.
There are other people that know they need to do it, and then they're just like, you know what I mean? Like you would rather put yourself in the category. Like those are also people that would like hire a coach. Like I'm not this guy. I'm going to do that. Right. And then other people are just headstrong. Like I'm going to do it on my own. And they just keep failing time and time. And they never get there. So that may seem like we're like, oh, the guy came back-to-back days. What are you going to do? Like you said, whatever needs to be done. Like,
Yeah. Holding him
stuff.
accountable
Yeah.
and
Cool.
very, very cool.
You ready?
Next update on Daniel's eye case 9 years from now in the MLB because he's
How
working on
long
his
did that
eyes.
Less than 10 minutes.
That was really good.
All right, so let's show the camera for posterity.
Oh man, I'm already. It makes me even like go slower. Look, I'm already stuttering over my words. My heart
10 seconds.
My heart rate has increased. My palms are sweaty.
It's probably vascular.
I can't get my words out because I'm short of breath.
Subclavian artery.
Oh
COVID.
man, poor timing. Okay, what do you know? I have a gymnast this week. Oh, let me give an update about my last gymnast I spoke about. It was knee pain.
11 minutes.
She's doing great. She's the one that was on, the NSAIDs and like the knee brace.
SJD and Oshkosh.
Yes, she's doing fantastic. We modified her practice and she's continuing to work towards her goal of competing this season with extremely limited pain right now. So I'm very excited how she's progressing. So, but this one is a gymnast as well with also knee pain. And she was referred to me by an ortho that we have a great relationship with. And originally an ATC had referred her to the ortho. So her knee pain started about a month ago. And just to give you a little background on her, she's 11 years old and she's done gymnastics for quite a while, but she took a good stretch of time off. I think around a year and a half off of gymnastics, came back within the last year. And then since June 1st has increased her workload per week what would this be? 400%? I'm bad at math. She went from 4 hours a week to now 16 hours a week.
Yeah.
That would be 400%. So she increased her workload 400%. She's also grown multiple inches over the last year.
Can we just pause for a second?
What's up?
You always make fun of me because I make you calculate the tip.
I'm very good at calculating tips.
16 divided by 4.
I just needed reassurance that was correct. So I wasn't.
I was just pointing out that.
I didn't want to be so bold.
I get a little guff when it's like, oh, it's $22. I could fucking figure it out. I just don't want to.
Well, I didn't want to be so bold and say this is 400%, and you guys be like, no, that's actually not. So I just wanted to. I wanted to involve you in my podcast.
Oh, you're.
I wanted to involve you in my case. Okay, my time is ticking. So she's increased her workload 400%, but not just the time of the amount of time at the gym, but also the intensity. She's switched programs and the intensity is greatly increased. So her knee pain started about a month ago, which is a couple weeks into her summer practice. And she saw the ATC at the gym. The ATC at the gym was nervous that she had subluxed her patella. So he refers to an ortho. She goes to the ortho. He clears her for
Slow down.
He clears her for everything and says she's hypermobile. She needs to go see
How old?
11. She needs to go see Dr. Sloan at the farm. She works with Gymnast. She's great at this. She really has no pathology, but she needs to be
Amazon orthotics done.
So she comes in to see me and sorry, I'm distracted.
Okay.
My baby just entered the room and you can feel her presence, Okay.
Speaking like a true mom.
So she comes in to see me, but whenever I start any new appointment with a gymnast, I always want to establish their goals, their long-term goals, but then also their short-term goals, because that's really going to influence a lot of how I approach treatment, honestly. And so her long-term goal, she's going to the Olympics. I love it. I love that ambition. Short-term goal.
She just go, do you know the statistics?
I'm not bursting any bubbles today.
Yeah.
Okay. I'm going to be supportive of that dream, but short-term goal, she wants to compete 2 different levels this fall, which is rare for a gymnast. So she's going to score out of one and then compete another one. So let's go back. She's increased her practice load 400% and she wants to compete double levels this fall. I mean, that is ambitious.
Yeah.
But you know what? I'm a part of her team. I'm here to help her achieve these goals in a safe way, right? So I'm taking that in consideration. I go through an exam and right away I take into account what the ortho said that she was hypermobile. But I want to see for myself through the exam because I have so many people. I mean, you guys know it. People come in like I'm double jointed, I'm hypermobile, and you're like, you are normal, or no, not, but he was absolutely correct. Very hypermobile, which kind of lends itself to gymnastics a good bit. So I wanted to go over the Baton scale because we did that with her. And the Baton scale is a 9-point scale. It's 5 different areas. Oh, poor baby. Give us a second, guys. Oh.
She hates the Baton scale.
She hates hypermobility.
She's also practicing to be a yodeler.
she has that she was saying bye to the animals at the zoo today. She was like, bye, and like her voice cracking. So there's 5 areas. You want to test the 5th pinky, basically the 5th finger, pulling it back into like dorsiflexion towards the forearm. And hers goes beyond the 90-degree mark.
Also, we have a video on YouTube.
Oh, yeah.
Baton scale of hypermobility.
Oh, please.
From 2014.
Yes.
So it's pinky,
Mm-hmm.
thumb to forearm,
Mm-hmm.
right? If you're looking here. So Monica, yeah.
Yeah.
So that's hypermobile. What's your pinky?
My party trick.
So the pinky's beyond 120 degrees.
It's beyond 90, but
Oh, really?
Yeah,
that's
I think it's
the
just 90.
90.
Okay.
But hers was approaching 120.
Elbow hyperextension.
Elbow past 10 degrees of hyperextension, which easily hit. Knees past 10 degrees of hyperextension, easily
on the
hit.
floor.
And she easily palms the floor.
What's the 10th point?
That's the skin,
Yeah.
the skin pliability. Boom. Superpower over here, Monica.
Yeah.
Monica.
She's in that realm.
Monica, we need to refilm the Bain scale and have Monica as the example.
I can't fall on the floor. I don't think my elbows are, no.
No, not 10
Pretty
degrees.
straight.
Yeah.
So I'm obviously
Can you check
not
this
ready. I'm not ready to diagnose her with Ehlers-Danlos or anything. And I think also the cool thing to know is she has zero history of injury. Knock on wood, right? She's never, had a ligamentous sprain or dislocation. So I'm taking that into consideration as well. But she definitely checks all the boxes for hypermobility. So back to her knee pain, she locates it just under her patella on the right side and says it hurts with the classic things like running, jumping, pounding, some of her leg conditioning that she does at the gym.
Like building a roof.
Yeah, she's pounding hammer and nail for sure at gymnastics practice. Yes.
No. 7 minutes and 15 seconds.
So exam showed just a classic knee orthopedic exam really showed nothing. I was pleasantly surprised that she had zero ligament laxity. Right and left were identical in how I perceived their the give,
Gumpiness.
the gumpiness, if you will. But at the same time, I could have compared those to my knees, and I feel like they would have been very, very similar. So I was surprised with that.
Like the
I'm saying-
example of pristine.
I'm saying that I am the example of pristine, but I'm also saying that I'm a tin man. So if she's on this side of the spectrum for mobility, I'm on the complete opposite.
Yeah.
I am the tin man.
And the one point why I asked the age is an 11-year-old girl that's a gymnast
Going to be
is
mobile.
going to be hypermobile.
Exactly.
Not just mobile, hypermobile for the most part.
Except when I was 11-year-old gymnast.
Right. But
'Cause
for the most part. So that's where, and then that's a lot of kids nowadays. We see a lot of kids come in from a variety of non-athletics that get diagnosed with hypermobility that kind of are, but it's a lack of activity. And you're not loading your musculoskeletal system. And guess what happens?
Gosh,
Laxity because of like excess load. So
that also, let me just say this off a side note here.
lack of, sorry.
This is a side note. How frustrating is it for me to get referrals for gymnasts that are told from other practitioners that they just need to stretch their hamstrings?
Yeah.
A gymnast like shin is touching their face in a straight leg raise, and they're like, "Oh, your hamstrings are tight. That's why your low back hurts." Okay, sorry. That was a side note. Back to the knee pain. So negative orthopedic exams on the right knee, except for she had some tenderness over patellar tendon, and that was exactly where her pain was, where she was feeling her pain. So I did some functional testing. Her squat, I kind of joked. I looked over her parents. I said, get this girl into Olympic lifting. It was beautiful. Now, something to note with her upon just standing is she does have quite a big collapse of her midfoot. You think of someone that's hitting those 9 out of 9 on a Bain scale, the midfoot really doesn't have much chance there. However, when she's moving, like when I watched her gait or when I observed her squat, it's almost like functionally strong there. There's
Usain Bolt syndrome.
a little bit. It's functional. It's functional. Like this is where a great example of where structural doesn't have to dictate like their function, right? So I'm not that concerned about it. Could we work on that eventually? Absolutely. But that's not where I think that this appointment needs to go. Everything moves beautifully. And then I bring her back to the table and I just kind of test her ability to create intra-abdominal pressure, as well as be able to stabilize her spine and disassociate her lower extremities. Because we know that the hip flexors and especially the rectus play a lot secondarily if we can't stabilize lumbar spine. And she had zero ability to do so. And so her and I kind of joked about how hard certain things were at the gym, like a simple hollow body hold, which every gymnast has to do multiple times during practice. She cannot do. She's just like, I cannot get my back flat on the ground. So she's kind of stuck in this extended position, inability to create any sort of anterior lumbar spine stability. So this first visit, I'm going to spend majority of my time kind of on some palliative care of the tendon. Like I do some soft tissue work. I definitely tape it. I'm just trying to bring some of her sensitivity down some, like give some like afferent input to the area. And then I also go over and I instruct her on how to start the very basics of some DNS work. So some basic diaphragmatic breathing and learning how to create that brace before we even do any sort of distal movement at all. And she struggled big time with this. So I think she felt like, man, this is all that I have to do is do this. I'm like, yes. And her mom, both of her parents were with her, which I love when parents are committed like that. But her mom worked with her every single day over this last week on it, which again, I love. And she came back and she was so excited to show me her progress, and she did great. Unfortunately, I wanted to use that first week and that first visit to almost to see what her prognosis would be. So I looked at the parents on the first visit and I said, I'm not ready to tell her, how she's going to be in a couple weeks. I want to see how she responds to today's visit. So the second visit, she comes back and she's like, I feel like my knees, like it's been more painful, which is disappointing. However, she's drastically increased what she's been doing at the gym. So she's like, I was able to vault this week for a couple of days. Well, she hadn't vaulted in a month. So she increased a ton of her impact and loading of the patellar tendon at the gym, but unfortunately experienced more pain at the end of the week because of that. So
more pain or same amount of pain?
She says more. Again, we're dealing with an 11-year-old. So she may have went, man, it's felt so good for 3 days and now it hurts again.
Because we always tell people same amount of pain, more activity, or same amount of activity, less pain is a win in sports medicine.
Equals. Yeah, that's good. So something I failed to mention on the last podcast that I wish that I would have went in more detail about was how
explanation of quantum physics of the universe.
Yeah, I'm going to need 30 more minutes. So go. But
That's impressive though. If you could
lot
do that
of
in 30 minutes.
Like a big old book.
A lot of my treatment, or not a lot of my patients, but a few of my patients, in particular gymnasts, a lot of my treatment is actually education. So it may not be hands-on, it may not be exercise prescription, but it's talking through how they can rework their practice and their training to better their outcomes. So that second visit, I hear I've increased my workload at the gym, but my pain is now back. Okay, so let's pump the brakes. I know that she wants to compete 2 different levels starting the end of August. We have a very short window of time to work with here. We have a girl that has grown over 6 inches in the last year. She's increased her workload 400%. We have to work smarter here.
How tall is she now?
She's very tall. For her age, she's very, very tall. And I mean, just gorgeous lines. So we went through her entire practice, and I kind of went through each skill. Okay, pull this out, leave this, pull this out, leave this. And we designed her practice around what she needed to do and what she potentially could do, and took out the kind of extra that wasn't going to serve her for her immediate short-term goals. In that way, she can continue doing gymnastics. I've been at 14 minutes and 10 seconds. Thank you, Beau. She can continue working towards that short-term goal while she builds up capacity of the patellar tendon. So she's like a classic case of outworking her capacity. So second visit was a lot of education, but I did increase. I'm not even looking at you. I did increase our work on that triple flexion position. So I call it the dead bug position with my gymnast, and she nailed it. I mean, she did great. So we started disassociating the lower extremity by doing some heel taps or some dead bugs. And then I started adding in some knee extensions. And then we put the feet down and did a classic glute bridge. But in my head, it's not a glute bridge. We're not working on her glutes. We're working on her ability to extend the hip while she stabilizes the lumbar spine. So when I say, we did some glute bridges with her, don't roll your eyes at it. It's the ability to stabilize lumbar spine and disassociate the hip, which is going to save that patella tendon over time. So we started with that. She killed it. We're going to follow back up in a week, and I'm excited to see her progress. I did want to point out that I did have a pain audit and a functional audit. So the pain audit was some jumping lunges because those kind of got her. So we pull those back each visit, or the last 2 visits that I've seen her. And then functional audit is in that triple flexion position. I just have her extend her knee or extend her leg, and I test the strength compared right and left. So, okay, there it is, guys.
That was it?
Done.
That was pretty good. Now, did you tape her? Because I feel like she's on my schedule next week for taping.
Oh, is she?
Yes.
I certainly did. Yeah.
Got
Huh. She should be on my schedule as well. Well, we can go over that.
I
but
don't
yeah,
know which day it is.
I definitely taped
This
her.
is now the Farm Productivity Podcast, where we talk about business. Standard.
Answer
That wasn't
question,
that
shoot
long.
us a review.
Yeah.
I don't really have any questions on it. I mean, you're thorough. It's
To say the least.
Where are you going to take this in the future? with her? Are you going to keep
Ooh.
progressing?
Yeah. So
Are you going to go different planes for core stability? Are we going to work on the hips or?
Moderator.
all of the above. I'm consult Monica on what I should do in the future. So Monica brings up a really good point. Something that we've met about this week in the farm is all as clinicians is kind of bettering our game as far as return to play and not focusing only on get rid of pain, which you can fall into so easily. So what Beau has really spearheaded here at the farm is, do you have a name for it, Beau?
What?
Our youth tracking.
Anti-bitch baby program for little people.
That needs to be turned into an acronym for sure. No, but like kind of a monthly check-in to go through FMS, top tier SFMA if there's pain, and just kind of monitor things and just make sure that we're not neglecting and only looking at just pain for return to play.
Mm-hmm.
But I love that idea. I mean, gymnastics, you have to have core stability in all planes, so I need to make sure, because something I may fall into is only sagittal training. So I love that. Thank you for the reminder.
Yeah.
What else we got?
Well, on the topic of like the return to play or just bettering patients, I feel like I'm trying to work on lately. I know it may not be athletes, but people that are active in their life. Like I had somebody with acute low back pain after a deadlift, and I feel like I'm going to struggle educating that patient on like how we need to keep progressing and build resiliency and make sure that we're able to stabilize correctly as he goes into deadlifts and increasing his weight. But I feel like once he's out of pain, he's going to be like, yeah, I'm done here. Like, I don't need to keep going back. So like, how do you go about educating a patient to continue working towards building some resilience?
Embarrass them. I'm kidding.
I know.
Well, I know with me, it's like, that's why I video them all. So it's like, once I get them out of pain, then I can show them, fantastic, we're out of pain now, this. Or what I always hate that I don't do enough is ask goals at the very, very beginning. Because like, if you're not asking goals, then what are you working towards?
Yeah, because right there, like, let's say somebody hurt, like they had low back pain with deadlifts, right? Like, was it high rep? Was it high weight? Then you can use that as a catalyst. Okay, what weight were you using? Like, load that puppy up in here, or sub-maximal load based on what they got hurt with. Can you pull 3 reps at what you got hurt with, or whatever the rep scheme was, right? Like sub-maximal, and then see if there's breakdowns, which you could video or just point out to them, and then show them like we had a guy out here that was complaining of cramping in his abdominal wall he would do a set of like 20 sit-ups as a CrossFit
that's what you're
goer.
doing.
Yeah.
I just saw this guy doing a ton of sit-ups.
He said,
Why are you trying to flex this guy so much?
He said for the past year, anytime he did sit-ups, CrossFit style, right? Like arms up, all this stuff, he couldn't do any more than 1 set of 20 because he'd cramp out. So like, okay. So we just had him start doing like prolonged exhales. He literally like couldn't find the cramp. Like just kept going. I was like, you can stop. Like stop doing sit-ups. But kind of that thing, like find their threshold, ask their goal. Is it outside of what they got hurt with? Because sometimes we don't know and we think they just need to do it. I think where the youth athlete thing is, I don't want to know their goal, right? It's almost like I don't want to know it hurts, so I make sure I make change. I don't want to know your goal because I want to make sure you're bulletproof against what you need to be bulletproof to do your sport, instead of you being like, a kid doesn't have a goal anyways, but like usually what we want to say is like, you need to be able to do X, Y, Z. And I think rarely do we actually put them against the rigors of that. Harder also to get somebody in the rigors of like fatigue, right? Like aerobic deficiency, put them in that status and then see how do they operate. But like, I mean, I don't know, do the best you can, but we're not great at return to play criteria overall.
I'd really like to know youth athletes' goals. That's where we differ.
I would too, but
I don't take it.
Your gymnast may say, my goal is to go to the Olympics. My goal is to compete in state.
That's why I break down importance of goals, short-term, long-term. Okay, can we get to that long-term if we compromise that short-term right now?
Right, but attaching their goal to, do you realize that you can't do this thing? My goal has to be that you do these things above your already stated capacity. Because like an adult's goal may be, I want to be able to play with my grandchildren, get down the floor and play with them. I get that. Okay. So my goal then for you to be able to do that is not that you can get down on the ground and play with your grandchildren. Because if you do that for a month, you may hit your capacity again. All of a sudden you're back in my office.
Oh, you build a buffer. your goal is going to go above and beyond getting on the floor.
It's not just a buffer. It's no different than Greg Cook, why he developed the FMS, right? He said, well, instead of practicing lunges, let's break down the lunge and practice the component parts of the lunge to then improve the lunge. It would be like, what do you lack that doesn't allow you to do that? And then that's what we're working on, rather than like, hey, if you hurt yourself doing deadlift, we could very easily say, well, let's load that barbell up, do that same weight. Did it, pretty good form. Cool, see it. And that's actually not a bad RTP versus like maybe just saying you're out of pain. We did some SFMA top tier change. Or you could say, man, I want to kind of see what happens if I had you row 1,000 meters, do 10 reps at 50%, do something else, and then go after that weight for 3 reps, 10% offloaded. Right? Like that's not a standard. Like there's no standard. It's just like, what's their worst thing? Are they terrible breathers? Are they, they're not aerobically fit? They're
the way that I kind of looked at that question, Monica, is say you have this gentleman with deadlift. I say you pick something that seems very simple in regard to a 300-pound deadlift. And then if they cannot do that, you point out, this is a fundamental thing, and you're trying to do this thing. There's some proof there that you still have work to do. That's what I was.
Yeah, I guess that's
and when I joke, you embarrass them. You enlighten them.
That's the education piece, but that's not the RTP.
No, but she asked about
my bad.
Education piece. Yeah. Am I wrong with that?
You're correct.
Thanks.
Yeah. Well, and I think what would be cool if, like, say a year or 6 months down the road, we start honing even more than just what we're checking now to be like, for each sport, what are the things we're looking at? Like I had my newest one that I started, and I looked at him, hamstring strain, all better on everything in here. And I just looked at him and I said, now it's going to be your baseball swing that's going to get it the most. And so he had 4 games in 2 days, and he came back in. I was like, how is it? And then like always, the mom answers, not he can't answer. And he goes, well, just like you said, the only thing that bothered him was the baseball swing. Yep. I was like, yep, okay.
Well, that's why I feel like we need coaches or trainers at some point, because you have to have like infantry soldiers to like do a bunch of the stuff. Like, it's not just like you get to the point you're there. It's like continuance, but not just like you continue progress. It's like managing the patient or managing the athlete or managing the person way outside of that. And I think that's what's missing overall in our field is like, we know that's what we're supposed to do, like rehab to performance. I honestly don't think we do it that well. I think we go back and we're like, hey, look, you're doing more weight on your deadlift, but then we're not like saying like, well, if we could really build a buffer around you, how do you do that? I don't think anybody's like being awesome at that. We could say FRC is building a better range of motion that's controlled at both end, ranges. And then where it's like, well, aerobic capacity, like Henshaw's over here doing that. It's like, well, actually, like, what's that person the worst at? Work on that thing and then see how you capitalize on that. But that's what I like to see us do is like, that's a hard ask. That's a big ask. Like if you have gymnasts, and not every gymnast surely is going to run into the same, like knee pain. It's surely not all that just, obviously it's not the same, but like you may be poorly undercapacitized from a conditioning standpoint, right? You may be affected pain, right? Well, okay, we have to treat your RTP like way different.
I work with a great strength conditioning coach that works with most of these gymnasts.
And I think you have to have that handoff, and that's where we need a better communication platform in here, and then more resources outside, which all clinics do. And I think if you can build that, and it's not just FMS, SFMA, and all that stuff, but just getting really good at like, how do you like talk to people about that stuff?
I'm going to find real fast on Instagram that
well, while you look at that, I was going to say the next thing I'm going to tell my baseball player who just started in this new program is if he complains again that his homework is to listen to Goggins for 24 hours straight.
That would be, like I said, instead of trying to think of this fancy return to play criteria, how do you test 8 TVs? Goggins campaigns. That's 8.
Hey guys, I just referenced a strength conditioning coach that I use for gymnastics. Her Instagram handle is LHP_gymnastics_strength_. Her name is Christina Myers.
Why should
hit her up?
Underscores?
I'm not sure, but
you gotta set yourself apart somehow.
Christina Myers, hit her up.
Is anybody on Instagram just a bunch of underscores? Like, is there like
just a blank space?
1 underscore guy and there's like 2 underscores?
I bet money you have to have a certain amount of characters.
We'll figure that out next time. All right.
Next time.
Give us some questions. Give us some cases maybe that you want to know. I mean, we can pull from anything. We see everything. So if you're like, we want more shoulder, elbow, wrist, foot, ankle, hip, knee, affective pain disorder,
Scapular fracture.
almost
Scapular
dead,
fracture. We have a lot to
saved.
pull from.
Single adjustment, curing blindness.
I may have a first rib dissection. This next one. Resection, not dissection. Resection. Okay. Tell me if I need to speed it up or slow it down.
You did pretty good. 14:45.
If I need to speed it up or slow it down.
See ya.